Hello everyone. There has been so many changes in sepsis. I think it's high time we give you an update on what's happening. Sepsis, the NCPOD 2015 report, the Just Say Sepsis, said it kills more people than breast, bowel, and prostate cancer combined in the UK. Around 200,000 cases of sepsis a year occur in the UK, and up to 60,000 deaths, which is considered an underestimate. 12,000 sepsis deaths a year may be avoidable of these. So, what are the main concerns in the management? They remain the same. That's not being spotted or being treated early enough. Where does the UK guidance come from? It essentially comes from the Sepsis Trust, which is a charitable organization and which is endorsed by the College of Emergency Medicine. And we have been making our guidance exactly as suggested by them. Now, very recently, that's in July 2016, the NICE guidance have come through. Sepsis, recognition, diagnosis, and early management. So that's going to, suggest all the future guidelines. And Sepsis Trust is likely to fall or bring things together exactly as NICE wants it. So where does the international guidance come from? Essentially, it comes from the Surviving Sepsis campaign, which is a joint collaboration between the Society of Critical Care Medicine and European Society of Intensive Care Medicine. What are the most common warning signs of sepsis? It may vary from patient to patient, but after discussion with sepsis survivors, the UK Sepsis Trust has compiled a list of the 6 most common signs: slurred speech or confusion, extreme shivering or muscle pain, passing no urine, severe breathlessness, I feel like I might die, skin mottled or discolored. What is the pathophysiology of sepsis? It is the pathophysiology. I thought it's probably worth a small mention here. Obviously, when the organism invades the body, it stimulates the innate immunity. Local inflammation happens and systemic inflammation happens. The capillaries start leaking plasma. The blood viscosity could increase. The leakage of plasma can cause interstitial edema. Therefore, oxygen may have to travel even more to reach the cells. The vessels start dilating. There could be myocardial dysfunction and the contractility could get affected. There could be an imbalance between procoagulants and anticoagulants. But very important to realize that it can go on to cause septic shock, which has almost all the components involved, which means it could be hypovolemia, it could have severe distributive or vasodilatory shock, and it could also have cardiogenic components where there could be systolic or diastolic dysfunction. So what is sepsis? What is the new definition? And this is it's a life-threatening organ dysfunction due to dysregulated host response in the setting of infection. Very important points here, something we were really looking forward to. In the setting of infection, we all understand it's dysregulated host response, and it's life-threatening organ dysfunction. So very key components here. This is the first revision since 2001 and reflect considerable advances made in the pathophysiology, management, and epidemiology of sepsis. Essentially, it helps in achieving greater clarity and consistency in how sepsis is diagnosed, reported, and treated. But very important, here it says in the setting of infection, but there are no clear guidelines to help the clinician identify the presence of infection or to casually link an identified organism with sepsis. Essentially, the clinician is reliant upon clinical suspicion derived from the signs and symptoms of infection, as well as supporting radiological, microbiological data, and response to therapy. Essentially, you have to suspect first. Now, organ dysfunction is defined by the 2016 Society of Critical Care Medicine, European Society of Intensive Care Medicine Task Force as an increase of 2 or more points in the SOFA, Sequential Organ Failure Assessment Score. The validity of this score was derived from critically ill patient with suspected sepsis by interrogating over 1 million intensive care unit electronic health record encounters from ICUs, both inside and outside the United States. So ICU patients were suspected as having infection if body fluids were cultured and they received antibiotics. The predictive scores like SOFA, SIRS, and logistic organ dysfunction syndrome were compared for their ability to predict mortality. Among critically ill patients with suspected sepsis, the predictive validity of the SOFA score for in-hospital mortality was superior to that for the SIRS criteria. Essentially, it was seen under the area under the receiver operating characteristic curve was 0.74 versus 0.64. That's what helps you determine this. Patients who fulfill these criteria have a predicted mortality of more than 10%, 10 or more. Although the predictive capacity of SOFA and LODS were similar, LODS is the logistic organ dysfunction syndrome is similar. SOFA is considered easier to calculate and was therefore recommended by the task force. Importantly, the SOFA score is an organ dysfunction score. It is not diagnostic of sepsis, nor does it identify those whose organ dysfunction is truly due to infection, but rather helps identify patients who potentially have a high risk of dying from infection. So now that you know the definition, when will you call it sepsis? The clinical criteria for it. So there is suspected or documented infection, an acute increase of 2 or more SOFA points, which is a proxy for organ dysfunction, I would call it sepsis. See that? I've just put it together there for you in that this little picture here, which says, in the earlier definition, if you had sepsis, you would call it sepsis if there was suspected infection plus the systemic inflammatory response syndrome. 2 out of the 4 criteria positive. You remember the SIRS, which was tachypnea, tachycardia, temperature changes, or total leukocyte count, high or low. So if there were 2 of these positive out of the 4, then you would call it SIRS positive. And along with suspected infection, you would call it sepsis. Now, obviously, the thrust has changed from a systemic inflammation to mortality indicators and organ failure. So that's why we end up with the SOFA score. When you have suspected infection plus the SOFA score positive, you start calling it sepsis. So what is septic shock? The new definition is the septic shock is a subset of sepsis in which underlying circulatory and cellular or metabolic abnormalities are profound enough to substantially increase mortality. Now this is interesting because earlier we used to, if you remember, the way we used to classify things were sepsis, severe sepsis, and septic shock. Now we say sepsis and septic shock. And it used to be considered a continuum, a spectrum. Now Septic shock is considered a subset of sepsis, in which underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. Again, the stress is on mortality. So, what clinical criteria would you use to call septic shock in a patient? So, the patient is in sepsis, has got persisting hypotension that ends up requiring vasopressor to keep a mean arterial pressure more than 65 millimeter mercury, and a lactate more than 2 millimole despite adequate volume resuscitation. So if somebody is in sepsis, they got persistent hypotension, which is unresponsive to fluids, and ends up needing, with lactates going up, and ends up needing vasopressors to maintain a mean arterial pressure more than 65, I would consider that or call that a septic shock. That would be my clinical criteria. So essentially, what is new? As you can see, and as I said before, the severe sepsis category has been removed. Sepsis itself is severe with a 10% mortality. So I think that's the thought that's gone behind there. And and it was a bit confusing having sepsis and then you call something which is severe sepsis and moving on to septic shock. Anyhow, one of the major issues with the SIRS criteria was that it misses 1 out of 8 patients with diagnosed severe sepsis. Notice this is not sepsis, but severe sepsis, which 1 out of patients that it misses out. It's a recent study from New England Journal of Medicine. How another way of thinking about this is it catches 7 out of 8 patients with severe sepsis for a sensitivity of 88%. Our focus has essentially shifted with our greater understanding from inflammation to organ failure and mortality. The use of SIRS criteria to identify those with sepsis has fallen out of favor, since it's considered by many experts that SIRS criteria are present in many hospitalized patients who do not develop an infection, and their ability to predict death is poor when compared with other scores such as the SOFA score. It was previously defined as 2 or more abnormalities in temperature, heart rate, respiration, or white cell count, as I said. We are talking about the SIRS criteria. SIRS may occur in several conditions related to or not to infection. Non-infectious conditions classically associated with SIRS include autoimmune disorders like pancreatitis, vasculitis, thromboembolism, burns, or surgery. So I would say it's good that it's gone. Always wanted to know, how does sepsis finally kill? I think this is just an overview, but it's good to know that. Sepsis essentially causes circulatory dysfunction, there's intravascular volume depletion, peripheral vasodilatation, myocardial depression, microcapillary injury, and it can cause, as we discussed earlier, metabolic injury, and essentially causing hypoperfusion and organ damage and death. So what is a new approach? So as you can see, the new approach essentially is meant to be that you suspect infection in somebody, then you screen them for sepsis. You can do a QSOFA score, a quick SOFA score, and yes, you can assess for any evidence of organ dysfunction, which means you do all the lab criteria, and then you can come to a formal SOFA scoring system. And then if there are 2 or more SOFA scores, then you would consider it as sepsis, essentially suggestive organ failure. But despite adequate fluid resuscitation in these patients, vasopressors, you end up needing vasopressors, and the lactate keeps going up, and it's more than 2, then you would consider it septic shock. So that chart gives you an idea about how to approach sepsis. So, in simple terms, I would say if somebody's, you have to suspect infection first, and then you have to be vigilant about it, and then you have to look for any evidence of organ failure. You can do a formal one, which is a SOFA score, or a bedside one, which is a QUIC SOFA. And as we have shown here, the QUIC SOFA variables are respiratory rate, mental status, and systolic blood pressure. And the SOFA variables are the PF ratio, PO2 by FiO2 ratio, which just shows you what is your oxygen tension when you give so much oxygen. Glasgow GCS score, mean arterial pressure, administration of vasopressors with type and dose, rate of infusion, serum creatinine or urine output, bilirubin, platelet count. So these are the factors which are the SOFA variables. I'll take you through that again. If the patient has 2 or 3 components of QUIC SOFA, the patient should be examined for organ failure. And organ dysfunction, which is a threshold that elevates uncomplicated infection to sepsis. The suggested method to assess for organ dysfunction is the sequential organ failure assessment, or the SOFA. When we say sequential, it means sepsis related here. Septic shocks differs from sepsis in that the complications are more severe and risk of patient's death is greater. The task force has identified 2 new clinical criteria that clinicians should use in diagnosing patients with septic shock, and these include persisting hypotension requiring vasopressors, as I said before, to maintain a mean arterial pressure more than 65 or more, blood lactate more than 2 millimole despite adequate volume resuscitation. And data indicates mortality rate for patients with these 2 conditions are in excess of 40%, or 4 times greater than those of patients with sepsis. So mortality rate is around 40%, or 4 times greater than for patients with sepsis alone. So how can you measure QSOFA? So essentially, the 2016 Society of Critical Care Medicine or European Society of Intensive Care Task Force have described an assessment score for patients outside the intensive care unit as a way to facilitate identification of potentially at risk of dying from sepsis. So outside the ITU. This score is a modified version of the sequential or sepsis-related organ failure assessment score of the SOFA score called the QUIC SOFA. A score 2 or more is associated with poor outcome due to sepsis. The Q SOFA is quite easy to calculate since it only has 3 components. As you can see, each of which are readily identifiable at the bedside and are allocated 1 point. Respiratory rate more than 22 per minute, altered mentation, systolic blood pressure less than 100 or less. Yeah, it's easy to think double figures. So the QSOFA was originally validated in 2016 as most useful in patients suspected as having sepsis outside of the intensive care unit. It has been prospectively validated in the emergency department and confirmed to be of less value in the ICU setting. See, this is just it just helps you identify QSOFA very quickly. Just helps you derive it very quickly. So it's all about 2s. QSOFA is 2 of your GCS, a respiratory rate of 22, and 2-figure systolic blood pressure. Any of 2 of these, then consider QSOFA positive. That's what it's trying to say. Now, very interesting, we use a new scoring system or the Mu scoring system. And if you superimpose the QSOFA on this, you will notice essentially the QSOFA scores, these are values at the far end of the new score. then the larger question is, how sensitive are these? Or are they mainly sensitive for patients at a high risk of deterioration? I think there are other studies which go on to support that. So, as we said, the organ dysfunction has become the major focus, and consequent mortality has become a major focus of the new definition of sepsis. Now, organ dysfunction can be identified based on the total SOFA score of more than 2 points. A score more than 2 points is associated with a mortality of 10%. In general, greater the number of organ failures, higher the mortality. The new sepsis definitions recommend using a change in baseline of the total SOFA score of 2 or more points to represent organ dysfunction. So the baseline is important. So a change from baseline is what we're talking about. Now, let's get back to Surviving Sepsis campaign. Now, they have revised all the guidelines now. That's following the definition of sepsis. Now they've gone on to refresh, review, and replace the guidelines. That's why I think going through it is quite important. Now, Surviving Sepsis campaign is a joint collaboration of the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. They are actually committed to reducing mortality from severe sepsis and septic shock worldwide. It was initiated in 2002, and 3 editions of evidence-based guidelines have been produced by them: 2004, 2008, 2012, and now recently they revised this 2015. In 2015, the 6-hour bundle, because they created the 3-hour bundle for sepsis and 6-hour bundle, and they went on to revise the 6-hour bundle in 2015, and that was in view of three major studies, and that caused them to revise their 6-hour bundle. And now they have gone in 2017, presently they have gone on to produce a new set of guidelines in total. So they work hard. Now, if you know the Sepsis 6, this is the UK version, a modified 1-hour bundle instead of the 3 hours that the Surviving Sepsis campaign talks about. They are, simply administering high flow oxygen, give broad spectrum antibiotics, give IV fluid challenges, take blood cultures, measure serum lactate and hemoglobin, measure accurately urine output. Essentially, you can double your patient's chance of survival. That's what the evidence says. What's important here is we got to understand the principles of circulatory shock, or the physiological principles underlying circulatory shock. Often I know that young students just try to learn all this, mug it up basically. But it's not about that. Just think, it's all about optimizing oxygen delivery in circulatory shock. Circulatory shock essentially is hypotension, systolic less than 100 or mean less than 65, and with increase in lactate, essentially due to lack of oxygen delivery. That's what this is about. So, and oxygen content is about optimizing oxygen content first, which means you're looking at the hemoglobin, you're looking at the oxygen saturation of hemoglobin, then you're trying to improve the cardiac output, and here you're trying to improve the preload component. That's why you're giving a fluid challenge, and then, you measure the effectiveness of what you do by doing a lactate, which just tells you if there's anaerobic metabolism is set in, are you delivering adequate or not. And then you look at the end organ perfusion or delivery of oxygen to your kidneys by just simply checking their function. That is, you check the urine output. So measure accurately hourly urine output. That's what you're doing. Essentially, the kidney is a filter in the cardiovascular system, and you're checking how well you're delivering oxygen now. So let's go and see the 6-hour bundle as it was from the 2012 Surviving Sepsis guideline. See, that's very interesting. As you can see, they were talking about using a central venous pressure measurement, mean arterial, urine output, central venous or mixed venous saturation. And so that's all part of the 6-hour bundle. So the goal of, I think it's very important we understand oxygen delivery, and the goal of fluid resuscitation in all these cases is basically early restoration of perfusion to prevent or limit multiple organ dysfunction as well as to reduce mortality. And the term early goal-directed therapy you would keep coming across, which is nothing but it refers to the administration of IV fluids within the first 6 hours of presentation using physiological targets to guide fluid management. Early goal-directed therapy has gained widespread acceptance in clinical practice, but the optimal targets are unknown. The early goal-directed targets, they are usually set for the central venous saturation as written here, central venous pressure, and mean arterial pressure, and urine output, and lactate clearance. So that's what used to be done. You just go by, you set these goals, you try to achieve this with fluids, or try to give fluids, or you improve each of the components of the oxygen delivery, which means you try to improve cardiac output, you can try to improve hemoglobin, and try to achieve this. But then came these trials, the PROCESS trial, the ARISE trial, and the PROMISE trial. These are large randomized controlled trials, which have taken in multiple nations basically. So PROCESS in US, the ARISE trial in Australian hospital, and the PROMISE trial in UK hospitals. I'll give you a minute to have a look at these. But what's important is, I'll go on to discuss this further. So essentially these multi-center randomized trial, the PROCESS trial of, as we showed you before, of 1,341 patients with septic shock reported no mortality benefit with protocol-based therapies. A protocol-based therapy that uses all of those and the early goal-directed targets, which is the mean arterial pressure, CVP, central venous saturation, urine output. And essentially these require central venous access. They were compared to a protocol that uses some of the targets, early goal-directed therapy targets, like mean arterial pressure, urine output, and where central access was not required, and to usual care, that is, no protocol used to direct fluid management. But what's interesting is whether you use a protocol with early goal-directed therapy, or some of the components where you don't use venous access, or a usual care, with no protocol in place, there was no difference in 60-day mortality between the groups. It was around 21%, 18%, 19% between these groups. Two other similarly designed multicenter randomized trials, I think, as I showed you before, ARISE and PROMISE, and these are patients with septic shock, also reported no mortality benefit from early goal-directed treatment. The lack of benefit may be attributed to overall better outcome in these studies, perhaps due to early administration of antibiotics. They all went on to receive early antibiotics, and to improved clinical performance by highly trained clinicians in academic centers during an era that follows an aggressive sepsis education and management campaign. I think now people understand, there's a better understanding of what sepsis is, or how to approach it, and what kind of bundles we have used. All these have trained our minds to act differently. So whether you follow a protocol or not, so you're likely to achieve good results. And as a consequence of these after the ARISE, PROCESS, and PROMISE trials in 2015, the 6-hour bundle has been updated by the Surviving Sepsis campaign. The 3-hour bundle is unaffected. It was revised in April 2015 by the Surviving Sepsis campaign executive committee. So, and as you can see, the changes that came about, what they're saying is document reassessment of volume status and tissue perfusion with either repeat focused examination. I think the focus changed from the CVP and the central venous saturation to other options. So you're reassessing the volume status and tissue perfusion with either repeated focus examination, including vital signs, cardiopulmonary, capillary fill, pulse, skin findings, or 2 of the following. Got a choice still if you want to check. Measure CVP, central venous saturation, and perform bedside cardiovascular ultrasound, perform dynamic assessment of fluid responsiveness with passive leg raise or fluid challenge. See, passive leg raise or fluid challenge has started coming here, and you can check fluid responsiveness. See, very important that we understand septic shock and the physiology. Not all patients with septic shock are fluid responsive, although most patients with septic shock have some component of intravascular volume depletion, but some don't. For example, a patient with underlying cardiomyopathy or copulmonale may present with septic shock and intravascular volume overload. Therefore, blindly giving every patient with sepsis an arbitrary amount of crestor prior to starting a vasopressor like norepinephrine makes little sense. It would be more logical to assess the patient's physiology, like using echocardiography, to determine tailored resuscitative strategy. Or this is what the experts think. And what I have to say here is, again, as I've said before, it's very important to know what really makes up the oxygen content of blood. It's essentially the hemoglobin concentration and how well it's saturated with oxygen, plus the dissolved fraction in plasma. That's what I've put it as formula here. Then the formula for oxygen delivery is cardiac output times the oxygen content. So it's a cardiac output, which is the flow which takes the oxygen content forward, okay? But the flow itself will not, the flow can only happen if there's a pressure gradient. So the driving pressure is the mean arterial pressure, isn't it? And so understanding blood pressure is very important. So what is blood pressure? It's a product of cardiac output and peripheral resistance. So you need a good flow and you need a good resistance in the hose. And then only, the pressure is generated. So you need a good pump, that's a cardiac output, and a good peripheral resistance. And then you have a good blood pressure generated. And cardiac output is a product of stroke volume and heart rate. So every stroke produces volume times the heart rate in a minute. That gives you the cardiac output. Now, cardiac output is dependent upon stroke volume. It's a product of stroke volume and heart rate, as we said. And stroke volume is dependent upon preload contractility and afterload. So these are very key understanding. Because when you approach a patient, if I were to approach a patient in A&E, the way I would approach is, as soon as I reach there, I'll always, obviously, you look at the ABC. But at the same time, I would think, oh, is the saturation okay? That's the first thing I can easily make a difference. And is the arterial oxygen saturation fine? Is the hemoglobin adequate? You never know. I've caught up with patients with hemorrhagic shock, and he missed out on the hemoglobin. He didn't, if you don't look at the hemoglobin. So it's very important. Immediately check the blood gas, check what the hemoglobin is, so you know the oxygen content is fine. Look at the components of cardiac output, which is stroke volume times heart rate. Heart rate, that's an emergency. If it's high or low, tachy or brady, can be, and it can be emergencies. And you follow the ALS guidelines. Essentially, it comes to some form of pharmaceutical therapy, or electrical therapy. That's what it is. And then look at the stroke volume components again. I would quickly look at the preload, how much fluid has been given. And then I would obviously want to know what the exercise tolerance for this patient is. I will try to evaluate something about the contractility and what has been the response to the preload. Did it raise the blood pressure? Was it a response at all? And does the patient have anything suggestive of an increase after load, like aortic stenosis? So these are things that I would quickly check, but I would go very systematically through them. So if somebody is fluid unresponsive, which means preload unresponsive, it could mean, just think about it, could mean a large preload deficit, a poor contractility, could be an afterload issue, or probably you did not look at the heart rate. Patient may be in severe AF or ventricular tachyarrhythmia. Anyhow, then once you optimize the cardiac output, go back to the formula on optimizing blood pressure, since blood pressure is a product of cardiac output and peripheral resistance, and ensure the peripheral resistance is up. So if not responding, I would try to increase the peripheral resistance by giving vasopressors. I may give a peripheral vasopressor like metraminol in emergency room, and then take the patient to ITU and give some NORAD. If the contractility is poor, I may go on to give some, NORAD may help, adrenaline, dobutamine. And then once I've raised the blood pressure, obviously that improves the mean arterial pressure, which is the main driving pressure. But flow, organ blood flow, is all dependent upon the pressure gradient. So there has to be good arterial pressure, and the venous pressure has to be on the lower side for the flow to occur. And it's inversely related to the organ vascular resistance. So I would raise the mean arterial pressure to the autoregulation range of the organs like kidney. So kidney, heart, and brain. Kidney's got autoregulation range around 70 to 170 millimeter mercury, and heart around 50 to 150 millimeter mercury mean arterial pressure, and the brain is 65 to 130 millimeter mercury mean arterial pressure. So it's very important we look at what the mean arterial pressure that we are achieving. So you see the kidneys are quite sensitive to a fall in blood pressure. But that means when the blood pressure falls below 70 or 65 millimeter mean arterial pressure, they are not, they become pressure dependent. The flow becomes pressure dependent. That's what it means. So as the pressure falls, the flow also falls. But within a higher range, they are basically filters. So they require a higher mean arterial pressure to perfuse them and to eliminate toxins. So if you give a lot of fluids, you can imagine the CVP could go high. The right side, you would just fill up the right side, and the CVP goes high, and essentially it can decrease the organ blood flow because the flow is dependent upon, directly proportional to the pressure gradient, the difference between the mean arterial and the venous pressure. Right, okay, so that's what I have tried to represent here. So exactly as I said, this is what I'll do as soon as I approach a patient. I'll try to fix the oxygen first. I'll not forget the hemoglobin. Simple blood gas will give you all that information. And I would try to improve, I'll obviously look at the heart rate if it needs sorting, if it needs shocking or amiodarone or pacing, or these things I'll look at. Then I would look at the preload, contractility, afterload, how much fluid has been given, has a patient shown a blood pressure response, has the cardiac output improved, and the blood pressure improved consequently. Does the patient have poor contractility, poor exercise tolerance, previous heart issues, previous echo reports? Is there aortic stenosis or pulmonary stenosis or pulmonary embolism likely? So then I would obviously think about peripheral resistance. The patient very vasodilated. If they're vasodilated, usually they will be peripherally very warm, and also the diastolic could be quite low. So then I would try to improve that if required, and improve the mean arterial pressure. Try to decrease the venous pressure if that's possible, or don't do much. And organ vascular resistance, I probably don't have much control at that point. And then improve the organ blood flow. so the kidneys get perfused. And especially, I'll target the kidneys first, and because they are very pressure dependent. So if you have these situations, call outreach immediately. If after delivering sepsis 6 the patient still has systolic BP less than 90, reduced level of consciousness despite resuscitation, respiratory rate more than 25 breaths per minute, lactate not reducing, or patient is clearly critically ill at any time. So do not forget to do this. Basically the critical care, they are linked to critical care. So essentially you are hiking up and referring the patient for greater care. A patient goes to ITU, what now? I think this is very important that we understand the kind of support we can offer to any patient in hospital includes primarily these: resuscitative, supportive care, definitive care, palliative care. And if we think on these generic terms, it helps us understand what care should patient receive and where should they go. You really start realizing your limitations. Probably you cannot do much of supportive care in the ward, so you'll have to ask for IT support. And if they require definitive care, like they may require debridement, removal of focus of infection, antibiotics, that'll all become definitive care. If nothing works, then they could be a palliative care patient. So it's very important we think in these terms. So now, to add to all our problems comes new set of guidelines from NICE quite recently. That's just been released before the Surviving Sepsis campaign guidelines. So now NICE recommendations are based on systematic reviews of best available evidence and explicit consideration of cost effectiveness. When minimal evidence is available, recommendations are based on the guideline development group's experience and opinion of what constitutes good practice. So the way they've approached is they've gone for pre-hospital and in-hospital, different age groups, and how to approach different age groups. They've stressed on a lot of descriptive patient factors and repeated stratified assessment. They're talking about very clear stratified assessment to make out, and they've approached it in a traffic light approach, which means, red, amber, green groups. Essentially high, moderate, and low risk. Not no risk, sorry, low risk. So, that's an infogram, BMJ infogram on the NICE guidelines. So it's like, it's like asking, do you think sepsis for everyone who presents with suspected infection, even if it's not typical of infection? I think the questions are quite directed at us and quite descriptive as well. Just like when a patient presents with chest pain, would you suspect MI? Would you suspect when they present with jaw pain? That's the equivalent of it, I would say. So would you suspect sepsis for everyone who presents with suspected infection, even if it's not typical of an infection? So, and they stress on good communication with particular attention to what patient has to say and the family or carer. What is the likely source of sepsis? Are these patients at risk of sepsis? So that's part of your assessment. Are you to focus on any clinical concerns with behavior, circulation, and respiration? So in your indicate these are areas they look for as indicators of clinical concern. Now, do you use a structured assessment for anyone with risk factors for sepsis and clinical abnormalities? Among those assessed in hospital with suspected sepsis, has a senior doctor reviewed the patient immediately if highest risk factors are present? Are those at high risk from sepsis offered intravenous antibiotics and fluid resuscitation within 1 hour of assessment? I think that's where all the focus is on. So these are the things that they're primarily focusing on. So that is a detailed risk assessment. As you can see, it looks basically at the vitals, various organs, behavior and history, and then in hospital, in primary care, which we are not discussing here, in hospital they divide into, as I said before, the traffic light system is applied, and that's how it goes. So this is essentially the nice adult 18 years and over in an acute hospital setting. So that's what it says. Now, what's important here is the Sepsis Trust produces the guidance, which is very similar. There are mild differences, and now we are trying to change our guidelines, which is exactly as per Sepsis Trust, and we are waiting actually changes from the Sepsis Trust to accommodate these mild changes. Now comes the Surviving Sepsis Guidelines, international guidelines for management of sepsis and septic shock. This is actually published on 18th January 2017. So an updated guideline was generated by 55 international experts representing 25 international organizations involved in the care of patients with sepsis and providing 93 recommendations on early management of sepsis and septic shock. There are numerous major advances in the revision of the guideline. Among the various topics covered, initial resuscitation and antibiotic therapy are the domains in which most important changes and advances were made. As I said, they are published in January 2017. So you can see how many areas, A, B, C, D, if you watch, there are so many recommended, 93 recommendations on early management of sepsis and septic shock. I'm not going to cover everything here, but I'll highlight what I think is important for the ward-based care. Now, what I like the most about it is their best practice statement says sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begins immediately. And second, they go on to say this is part of initial resuscitation guidelines. Okay, we recommend that in resuscitation from sepsis-induced hypoperfusion, at least 30 ml per kilogram of IV crystalloid fluid be given within the first 3 hours. Strong recommendation, low quality of evidence. See, sepsis itself is potentially life-threatening, and mortality rate from sepsis are higher than heart attack, stroke, or trauma. So I think sepsis needs to be reviewed with the same urgency as these other life-threatening conditions, because you know that early treatment can decrease mortality. And they go on to recommend that following initial fluid resuscitation, additional fluids be guided by frequent assessment of hemodynamic status. So I think the stress is on frequent assessment of hemodynamic status. So don't just pump fluid into people, but just watch whether there's a response or they're improving or not improving. So fluid responsiveness is very important, and I think that's a good thrust there. We recommend further hemodynamic assessments such as assessing cardiac function to determine the type of shock if the clinical examination does not lead to a clear diagnosis. I think this is very key. I remember situations where we have come across patients who are septic, but they may be having severe aortic regurgitation due to infected endocarditis, or they have taken an MI, or they have got diabetic ketoacidosis. So there could be many reasons, and therefore, when you assess circulatory shock, don't just assume it's septic shock because the patient has a likely infection or suspected infection. You really have to rule out all kinds of shock. So do not forget it. It's so important, so key. So that's where the importance of assessing cardiac function. I usually go for an early echocardiogram to rule out other causes. And I've been lucky many times because I've been able to find things which could have been missed or which have been missed. And they're going to recommend an initial target mean arterial pressure of 65 in patients with septic shock requiring vasopressors. A strong recommendation with moderate quality of evidence. That's reasonable. I would say 65 millimeter mercury in patients with septic shock requiring vasopressors. So initial target mean. And we suggest guiding resuscitation to normalize lactate in patients with elevated lactate levels as a marker of tissue hypoperfusion. It's a weak recommendation, low quality of evidence. It's quite important to understand that increasing lactate doesn't just it need not mean hypoperfusion by itself. Very high sympathetic activity can lead to increase in lactate. So it's not a direct indicator. It could be. So no wonder it's a low quality of evidence and weak recommendation. We suggest that dynamic overstatic variables be used to predict fluid responsiveness where available. So weak recommendation, low quality of evidence. So they suggest dynamic overstatic variables be used to predict fluid responsiveness. So I think that's where passive leg racing is likely to get very important in the ward area. Now, they go on to say, we recommend that a specific anatomic diagnosis of infection requiring emergent source control be identified or excluded as rapidly as possible in patients with sepsis or septic shock, and that any required source control intervention be implemented as soon as medically and logistically practical after the diagnosis is made. I think this is very key. So you really don't want to be sitting on a potential or likely source of infection, which could be, so it's very important we really ask ourselves, where is the infection? And does it need to be drained? Does it need to be the source be controlled at the earliest? So the focus has shifted from to emergencies and to deal with things faster. So this is a very welcome change. Something we have observed as well. We go to the wards, to the surgical wards. You may have medical cases sitting there, which again, people can be missing things. Or we go to a medical ward, and surgical source control may be delayed, or because you have not exposed the patient fully, or so. Maybe having gangrene on the foot. I've seen those similar situations. We recommend prompt removal of intravascular access devices that are a possible source of sepsis or septic shock after other vascular access has been established. Quite important. So these are some of the recommendations that they're placed, but essentially it's all very sensible recommendations. Not others are. I wouldn't say there's a gross difference from what has been there. Some differences or some changes, but I've tried to highlight what is relevant and important while working in a ward area or in A&E initially. So how would I sum it up as? I think what's important is sepsis skills is very important. You should recognize, intervene, and treat early. If not suspected, you may miss. See, there's a lot of banking on you suspecting an infection. So it's very important you suspect, and that could make a difference. If you suspect, if you're not sure, go for a repeat assessment. In a sick patient, consider sepsis, irrespective. Forget all the other things. But if the patient is sick, consider sepsis. Start antibiotics early. In any isolated organ failure, consider sepsis irrespective of all these scoring system. So if you see any organ failure, consider sepsis as the first thing. And then, look at other, because sepsis is more life-threatening than a lot of other conditions. So why not think of something which is, most life-threatening, like you would think of A, B, C. And A first in. If fluid unresponsive hypotension, do not wait, escalate, and rule out other causes of shock. I think this is so key. As I said, if somebody is not preload responsive, doesn't mean it's just a problem with, it could be a large preload deficit. It could mean there's a problem with contractility. There could be a problem with afterload. There could be a problem with heart rate. There could be a problem with peripheral resistance. So please do not miss out these. An increasing lactate or base deficit could be easy cues to multi-organ failure. I think yes, obviously everybody knows that, but people don't look at base deficit. Sometimes they may give you early cues to your AKI. So even before the creatinine comes in, your base deficit could be going up, and that could suggest early AKI. And if AKI or any other organ failure, refer to ITU team if appropriate. I would say always refer if appropriate. Don't increase the burden of work for ITU team. But if it's appropriate, don't delay. And any organ failure, including AKI. And communicate using the lingo sepsis and septic shock. This is very important because I've seen a lot of, when I go through mortality reports, what I notice is people do write, when somebody writes sepsis or septic shock, the escalation falls in correctly. The seriousness increases. The referrals happen correctly. So it's very important if somebody says it's sepsis or you think there's organ failure, you suspect sepsis, you keep maintaining that communication, highlight it and maintain it. It has an effect on a lot of factors. Finally, the way things get coded, finally, how it reflects in mortality and so on and so forth. Well, I would say thank you for listening to me, and I think you really make the difference. Good. Thank you.